Hello, my name is Katarina Ostojic. I'm delighted to share this DMCN podcast on behalf of our team of authors. Our paper titled Biofeedback Assisted Relaxation Training and Distraction Therapy for Pain in Children Undergoing Botulinum Neurotoxin A Injections, a crossover randomized control trial, was recently published in DMCN. I would like to acknowledge our institutions and funding bodies for their support and the children and young people who participated in this research project. Botulinum neurotoxin A, or BoNT-A injections, are routinely administered to individuals with neurological physical disabilities, including children with cerebral palsy or CP. This treatment is generally offered on a 4 to 12 monthly basis. Many centres support children undergoing BoNT-A injections with topical anaesthetic cream and/or sedation or general anaesthetic. Use of these agents may be influenced by the patient's needs and personal preferences, and the availability of resources in the local clinical setting. Non-pharmacological strategies are also important to support children during painful procedures, including BoNT-A injections. However, there is limited research to support non-pharmacological approaches for children undergoing BoNT-A treatment. We aim to investigate the efficacy of biofeedback assisted relaxation training, or BART, delivered through the Bright Hearts application, compared with distraction therapy for procedural pain in children undergoing BoNT-A injections using a crossover RCT design. We hypothesized that children would self-report experiencing less pain during BoNT-A treatment when using BART compared with distraction therapy. Secondary outcomes of interest included anxiety, fear, and satisfaction with the intervention. Bright Hearts is an iOS application for delivery of BART via interactive visual and auditory artwork responding to changes in heart rate. It aims to teach the participant to engage in deliberate relaxation to lower the average heart rate, a physiological parameter of pain and anxiety. Participants in our study were children aged 7 to 18 years with a diagnosis of cerebral palsy, acquired brain injury, or hereditary spastic paresis, and were fluent English speakers. All participants had chosen to undergo BoNT-A treatment with topical anesthesia, but without sedation or general anaesthetic. The study was conducted at the Rehabilitation Department, the Children's Hospital at Westmead in Sydney, Australia. Participants were randomized to receive BART during one BoNT-A treatment, followed by distraction therapy in the subsequent treatment, or the reversed. All participants were required to undergo 2 consecutive BoNT-A treatments without sedation. An extensive list of outcome measures were captured before, during, and immediately after the BoNT-A procedure. Whilst in the waiting room, we captured children's pre-procedural anxiety. During the procedure, the research investigator captured observational data on the intervention engagement and behavioural assessment of pain using the FLAC. And immediately after the procedure, we collected child self-report measures of pain, anxiety, and fear, which I'll further discuss. The primary outcome measure was child self-report of overall pain and worst pain using the FACES pain scale revised. Secondary outcome measures included anxiety during and anxiety immediately after the BoNT-A treatment, as well as fear during the treatment and fear of their future BoNT-A treatment. Paired t-tests were performed to determine a treatment effect, the mean difference in pain, anxiety, and fear when using BART compared with distraction therapy, a period effect, the mean difference in these outcome measures at the first BoNT-A treatment compared to the second BoNT-A treatment, and a carryover effect was analysed using linear mixed effects models to investigate the impact of receiving BART during the first BoNT-A treatment on outcome variables at both BoNT-A time points. We investigated the treatment period and carryover effect for all outcome measures, i.e. pain, anxiety, and fear. We also investigated participant characteristics associated with poorer outcomes, including age, GMFCS level, and pre-procedural anxiety. Subsequently, any participant characteristics of significance were then added to the carryover effects model to create an adjusted model. This was done to investigate possible confounding effects of these participant characteristics. 48 children enrolled in the study and 10 withdrew, leaving 38 participants who completed both intervention arms and were included in the primary analysis. Reasons for withdrawal and forms of distraction can be found in the full text. Participant characteristics can be found in detail in our full text. In summary, 34 of the 38 participants had a primary diagnosis of CP, most functioning in GMFCS levels 1 to 2, and 13 of the 38 participants had previously undergone BoNT-A treatment without sedation. Our main findings are as followed. Children reporting higher pre-procedural state anxiety did worse on all outcome measures. Younger children reported higher worst pain, anxiety during, anxiety after, and fear during the treatment. And children functioning at GMFCS levels 3 to 4 reported higher overall pain, worse pain, and anxiety during the treatment. We found no significant treatment effect. That is, no significant differences in pain, anxiety, or fear between Bright Hearts and distraction therapy. We found one significant period effect, with children reporting less anxiety during the procedure at their second BoNT-A treatment compared to the first. And we found significant carryover effects, with participants reporting significantly lower overall pain, lower worst pain, lower anxiety during, and anxiety immediately after the procedure across both BoNT-A treatments if they used BART first. This carryover effect remains significant even after adjusting for significant individual factors. Strengths of this study included the use of child self-report, use of validated outcome measures, an assessment of outcomes known to impact the pain experience, for example, anxiety and fear, per the biopsychosocial model of pain. BART was delivered by the Bright Hearts application, designed specifically for paediatric use, requiring minimal training and accessible on iOS devices. Our study was limited by the exclusion of children with a moderate intellectual disability or greater, who are more likely to function at GMFCS levels 4 and 5, and frequently undergo painful medical procedures. Participants in this study volunteered to undergo BoNT-A injections without sedation, and their pain experience may differ to other children undergoing treatment. Also, the interventions investigated are not suitable for all abilities. So where to from here? The positive carryover effect of children reporting less pain and anxiety at both treatments if they use BART first is encouraging and warrants future research. It may suggest that children learned a skill when using BART via Bright Hearts, which they applied during their subsequent BoNT-A procedure. Children functioning at GMFCS levels 3 to 4 were more likely to experience increased pain and anxiety, even after controlling for other potential factors. Future research is needed to understand the experience of pain in this subgroup, who are more likely to experience complex and chronic pain and have repeated exposure to painful medical procedures. Future research is needed to adapt and deliver psychological interventions to children with varying intellectual abilities, communication access needs, and those with more complex anxiety, fear, or aversion related to medical procedures. Our recommendations: young people with CP undergo frequent medical procedures, many of which are planned and/or repeated. Thus, there is an opportunity for clinicians to anticipate and better identify this group of children through routine screening and better support young people via timely delivery of non-pharmacological interventions suited to their developmental and psychosocial needs. Also, these non-pharmacological strategies may be beneficial during other procedures and therapies, as well as other diagnostic groups undergoing recurrent painful procedures. A very big thank you to all the people who made this research possible. If you have further questions, please don't hesitate to contact me via email provided. Thank you.